Well, kia ora koutou and talofa lava, everyone. Welcome to tonight's Goodfellow Unit Webinar. This webinar is part of the monthly Te Tiri Whakāro series by Te Whatu Ora. I'm Dr Hazel Fuyava. I'm a GP in West Auckland and I work for the Goodfellow Unit. Tonight we have three speakers, which I will introduce now. Firstly, we have Dr Tom Wilkinson with us. He was on one of these webinars recently, so welcome back, Tom. He is an endocrinologist and is speaking on automated insulin delivery systems for diabetes. Tom is based in Ōtautahi, Christchurch, and he is a full-time PhD candidate through the University of Otago, investigating closed-loop systems in type 1 and type 2 diabetes. After Tom, we have Dr May Soh, and she is going to be speaking on thyroid disorders in pregnancy. May is an obstetric physician and a rheumatologist, and she's the head of Department of Obstetric Medicine at Te Whatu Ora, Counties Manukau. Lastly, we'll have Dr Sue Tutty providing some clinical updates for us. Sue is a GP and a primary care advisor for Te Whatu Ora, Counties Manukau. So I'll now hand over to Tom.
Thank you again. So for those who were here a month ago, last month I spoke to this webinar about really exciting developments in diabetes technology, at that time with a focus on continuous glucose monitors. Tonight I'm going to pivot a bit towards automated insulin delivery, which is really the most important way in which these new technologies, which are now fully funded for people with type 1 diabetes, are being transformative to diabetes outcomes. In the process, we will touch on some of the stuff I talked about CGM last time as a refresher, and because it's necessary to understand these systems. If you didn't hear my last webinar, don't worry, I've tried to make this be standalone on its own, so hopefully it all makes sense, even if you didn't hear my last talk about CGM. So, automated insulin delivery. To start off with, it's just helpful to give an overview of these devices and what they are. So, these are the main devices which we've now got for management predominantly of type 1 diabetes. So on the right, we've got continuous glucose monitors. So these are sensors that sit in the interstitial fluid and measure glucose levels in real time and have real-time Bluetooth capability to share those glucose levels. Insulin pumps, I'll get to in a moment, but they're essentially insulin delivery devices, but also with real-time Bluetooth. So because we've got these insulin delivery, so this is where insulin delivery is modulated in real time in response to actual glucose values. That can either occur through an algorithm stored within the pump itself, or sometimes with an algorithm stored on a smartphone that acts as an intermediary between the devices. So I'll just briefly talk about insulin pumps. So insulin pumps they're actually pretty simple devices. Insulin pumps have been around for about 40 years now, and the fundamentals are pretty straightforward. These are devices that deliver a continuous subcutaneous infusion of insulin. It's important to note that they use only rapid-acting insulin, most commonly NovoRapid or Humalog. Patients on an insulin pump do not require long-acting insulin such as Lantus, and this is because they're receiving a continuous infusion of that rapid-acting insulin. And these pumps have Bluetooth capability. In terms of practical aspects of prescribing, someone on a pump is going to require prescriptions for 4 things. They need a prescription for the pump itself, whether that's a once every 4-year thing to get that device. Prescriptions for the reservoir. So this is a device which they fill up with insulin and then put into the pump itself. They're going to need prescriptions for infusion sets. That's how the insulin's delivered. And those two terms, reservoirs and infusion sets, they're collectively termed pump consumables. They come with their own special authority and they require 3 monthly prescriptions and 2 yearly special authority renewals in insulin, which the patient will load into the pump. So once you've got your pump group working with a continuous glucose monitor, you can run automated insulin delivery. So these systems automatically, it's pretty straightforward, they'll automatically give more insulin when glucose is high or when it's rising up. They will reduce or suspend insulin when glucose is low or falling. Now, it's important to note that with the currently available systems, users are still advised to manually give insulin prior to planned meals. These systems are not intended to automate meals. What I've got here on the slide is the typical tracing you might see of someone on an AID system. So at the top, you've got glucose. At the bottom, you've got insulin delivery, and you'll see that there's often quite marked fluctuations in insulin delivery, even overnight, which results in relatively stable glucose levels. And you can also see 2 instances where this user has delivered manual boluses around meal times. Now, we've had funding for CGM since the 1st of October and a much greatly expanded funding for insulin pumps since the 1st of October. This is really exciting. It's facilitating access to this really important technology. However, it's also creating considerable workload. And that's led to repeated discussions about where does primary care sit, where does secondary care sit. So the following should only occur in diabetes specialist services. This isn't just my opinion. I think you'd struggle to find anyone in the country who disagrees, any endocrinologist in the country who disagrees with this. That is that within a specialist diabetes multidisciplinary team. Same goes for initiation of AID in an existing insulin pump user. Now, I just wanted to bring it up because I think there has been some confusion about this. There have been a handful, just a small number, but a handful of patients who have been receiving prescriptions for insulin pumps from the usual primary care providers with no plan for training to start the pump. That creates massive problems. So when you prescribe a pump, the next step is for that patient to go into a pump start course, which takes several hours of multidisciplinary expertise and involves pump representatives. That is there to mitigate clinical risk, which I will get to later. But also importantly, if a patient starts a pump outside of that setting, that may void the pump warranty. So prescribing a new pump without a scheduled date for training with a multidisciplinary team is dangerous and may void the pump warranty. I think that's really important to emphasise. However, turning more to where primary care sits, this is what I think primary care can be really helpful with. Firstly, as we discussed last month, CGM prescriptions carry minimal risk and are really helpful for everyone. Last time about if someone's not in an AID system, there are standalone CGMs, which are not AID compatible, but still offer clinical benefit. And those are very appropriate to be started in primary care. Similarly, renewing scripts and special authorities for the pump consumables, really helpful. But finally, and this is what I want to spend this talk talking about, I think it's really helpful for everyone to be aware of the strengths on these systems and communicate with patients wanting to go on these systems. Also helpful to be aware that, as discussed last time and mentioned already, there's likely to be a very long wait list for insulin pump initiation. We're talking a matter of several years in some centres, just because of the intensive resourcing staffing required to run a pump start. So with that in mind, let's talk a bit about AID systems, strengths and limitations. So these are the AID systems that you may come across. So at the top, I've got Control-IQ and CAM-APS. These are the 2 systems which are now funded in New Zealand. The Control-IQ runs with a Tandem T Slim pump, CAM-APS with a MyLife Ipso pump. Now, probably the most important difference is that Control-IQ, the algorithm is located on the pump itself, so the CGM talks directly to the pump. For CAM-APS, the algorithm is located on a separate smartphone. Currently, it needs to be an Android smartphone, although apparently iPhone compatibility is coming next year. They've both got broad compatibility with a CGM options. Down below, I've just mentioned there's 2 other systems. So Medtronic insulin pumps, there are a number of people currently on Medtronic pumps, which are going to be delisted in a couple of years' time. These people may be running the Medtronic closed-loop system called 780G. And there's a very niche area of a system called Android APS, which is very technical and we won't get much further into. So AID. But first, this is just a repeat of last time interpreting CGM data, but useful because we're going to delve into a lot of CGM data shortly. So when a patient's on a CGM, what you can get is you can get a quick group of overview statistics based ideally on at least 14 days of data. And this can tell you a lot straight away. So this is an example of the report you might get from a Dexcom device. The key figures I look at myself is firstly, how often was the CGM active? In this case, 99% of the time, that's good. Secondly, and probably most importantly, is this figure termed time in range. This is the percentage of CGM values between 3.9 and 10.0, and this is the primary outcome metric in most diabetes technology clinical trials. The next statistic you might look at is time below range, so it's percentage of readings less than 3.9. And finally, the CGM can give you an estimate of HbA1c. But time and range is the main one. So I've listed here some important clinical trials of the AID systems available in New Zealand. I listed this wall of text not to delve into the trials at all, but to highlight one thing, which is if you look at the time and range achieved for all these systems across multiple trials, it's remarkably consistent across patient groups and across different algorithms and different pumps. And these different algorithms have all been written and engineered in completely different ways, but they all achieve roughly available in New Zealand achieved mean time and range of around 70% in clinical trials. And just for context, a sustained time and range of around 70% would be expected to result in HbA1c of around 50 millimoles per mole. Now, it's worth noting, therefore, that an average user of an AID system will have 30% of recordings greater than 10. So for 6 to 7 hours per day, they will be hyperglycemic, and that is expected. That is what happens with these systems. It's also worth noting that these systems produce minimal hypoglycemia, but not zero hypoglycemia. Hypoglycemia still occurs. So to put into context, this is an ambulatory glucose profile. So this is another useful summary you can get from CGM. This shows per hour of day the median glucose for that particular person and then percentile ranges around it. I got this from someone on a closed loop system achieving exactly 70% time and range. This shows you what's a very typical profile. You see very tight control overnight, and then during the day, it's much more in the way of glycemic fluctuations. So it's pretty good, and this can make a big difference to some people, but it's not 100% time and range, and that can surprise some people who view this as a so-called artificial pancreas. So why is this? So firstly, closed-loop systems, interestingly, closed-loop systems is not a new thing. We think about the cruise control in your car, the thermostat in your heat pump at home, steam engine, which is a very old device that regulates constant speed of the steam engine, and that in itself is a closed loop system. So this idea of closed loop is not a new engineering concept. And the fundamental principles are pretty simple. If your glucose is going high driven insulin, glucose is going low driven less. So why can't these systems achieve 100% time and range? Well, there's three factors. Firstly, speed of insulin. Secondly, the sheer magnitude of fluctuations required. And thirdly, time out of automation. So we'll talk about all three of these. So the first thing to note is that our so-called rapid acting insulin is not actually that rapid. On the right here, I've got, this is data from an animal study where they infused IV dextrose and then took samples of insulin directly from the portal vein. And what you can see is that in normal physiology, venous insulin peaks at about 1 minute after glucose rises and drops down very quickly. On the left, I've got here graphs and pharmacokinetic studies of the rapid-acting insulin analogs showing plasma activity over time. And you can see that plasma activity peaks at around 1 hour after administration. So it's actually very slow, which means it can't react to changes in glucose nearly as rapidly as normal physiology can. So this is the reason why patients using these systems are still advised to give manual insulin. A system where you don't give an insulin bolus prior to meals, this is what would happen. You'll have a meal, glucose will rise. At the point that glucose rises, the system will detect that and give a bolus of insulin. Have it on the blue line matches the actual activity of that insulin after the time of delivery. While it's taken a while for that insulin to kick in, you're going to get hyperglycemia until the insulin kicks in. So the result is a significant period of time above range, solely due to the slow onset of insulin. You can't engineer your way out of that. What you can do is ask the patient to pre-bolus or bolus at the time of meal consumption, and that will significantly mitigate that postprandial spike. So that's the speed of insulin. Second thing is the sheer magnitude of fluctuations in insulin delivery required. I think a really helpful analogy is that of a self-driving car, and we'll come back to that in a moment. But you know, self-driving cars is an emerging technology, and I sort of model it this way. If someone is asleep, not exercising, not eating, it's pretty straightforward to achieve control. As soon as someone starts living their life, eating food, exercising, it gets very difficult. The amount of insulin required to cover a meal is a substantial proportion of your daily requirement. When you exercise, your insulin requirements dramatically reduce. It would be like expecting a self-driving car to navigate a windy alpine pass. Possibly it could do it, but it's going to do so in a very cautious way, which is how many. So this is from one of the RCTs of control IQ, in this case, of an AID system. And this is very typical. So what we see mapped here is time and range by time of day. So in this graph, a higher point indicates better glycemic control. And we can see here we're comparing closed loop or AID users to the control group. And what you can see is during the day, there's actually not that much difference between AID and the control, non-AID. And I think that just reflects the difficulty for an automated system to maintain control in the face of everyday challenges. Having said that, there's really two important points to note here. Firstly, and we see this in multiple systems, multiple trials, you notice a considerable difference overnight. This is where these systems really come into their own. You can almost guarantee that most nights you're going to spend most of the night in target glucose range. And one of the really life-changing things for many people is knowing that they will almost always wake up with a normal glucose value, regardless of what they were when they went to bed, and that's really powerful. The second thing to note is many of the pivotal trials of AID systems recruited only participants with very good or relatively good control at baseline. Of AID and people with very poor control. And so this is recent data from a New Zealand study of New Zealand RCT using a closed loop system in participants with very poor baseline control. And you can see here that people randomized to AID had massive improvements in the glycemia compared to control, which just serves to illustrate another important point, which is the people who have the most to gain from these systems are the people with the highest HbA1cs. And so when it comes to services prioritizing who goes on pumps and AID first, those are the groups that need to be offered that opportunity first up. Next, I just want to talk about system failure. This happens. It's inevitable. Technologies can be fickle. So with AID, periods off automation are frequent. The CGM, the sensor, can fail. Each sensor has a warm-up period of up to 2 hours. During that 2 hours, you're not in automation. If you're reliant on a phone, the phone could run out of charge. It could have all sorts of issues with the Bluetooth connection. These happen all the time. Importantly, these systems are all programmed so that when there was a disconnection from Bluetooth, the pump will default to a pre-programmed basal insulin delivery rate. And if the pump has been initiated well, that should have been programmed at a rate sensible for that individual patient based on the usual insulin requirements. So periods of automation are frequent. It's one of the reasons why you don't see time and range 100%, but generally it is significant and requires urgent attention. So it's worth remembering that people on pumps are only receiving rapid insulin. What that means is if that insulin delivery is interrupted, they're going to rapidly run out of insulin and they're going to rapidly become ketotic, much more easily than someone who would be taking Lantus. Most commonly, this occurs when the infusion set occludes, and that can just be by having the cannula bumped. It cannot even be visually obvious. When that happens, insulin delivery is obviously interrupted. It's for this reason, it's interesting to note, multiple studies have shown a reduction in HbA1c after initiating an insulin pump, but some of these studies do report an increased risk of DKA compared to people on injections, despite the lowered HbA1c, and that just reflects the issue of pump failure and recognition of it. And this is one of the key reasons why pump and AID initiation should only occur within a diabetes specialist service able to provide education and support, because we need patients to be able to recognize failure and manage it, because otherwise it can go bad very quickly. The advice we give, and this is useful to know for someone presenting on a pump, is that if someone on a pump has an elevated glucose and it's weird, so that's not they just had a pizza, it's weird, there's no reason for the glucose to be elevated, then you need to at that point assume the pump's not working. We advise the patients in this situation to check their ketones. If the ketones are more than 1, that's a very at the insulin with a pen. That way they know that at least something has been given. Next step is to do a check of the system, check the cannula site, check the tubing, check the pump. And just to note that even if nothing's visually obvious and the ketones aren't elevated, there may still be an issue. And I often advise patients to replace their infusion set if they've got prolonged, unexplained hypoglycemia, because there could be something wrong with that set. So that's AID system failure. I just next want to briefly talk about AID intolerance. This is important to be aware of and to think about when starting patients. So some people, even though AID is amazing and can make amazing differences to most people, for some people it's just not their thing, and some people do discontinue AID systems. And it's almost always due to one of two things: device intolerance or lack of trust. I've got some graphics here to kind of illustrate some of these points. So CGM rashes do occur quite frequently, so you can get a rash to your CGM. Now, there are ways to mitigate this and manage this. We do have good ways to manage it, but that's one thing that can lead to someone thinking, I've had enough of this. It's worth remembering that an insulin pump is something that you're wearing and it's attached to your body 24/7, even in your sleep. Some people, that can be a real nuisance. For some people, it can be a very visual signal. And just this middle picture here, this is the sheer volume of supplies required to run an AID system for 3 months. That's all your infusion sets, reservoirs, and CGM supplies. Lack of trust. Once again, I come back to this idea of a self-driving car. I was recently test driving a car that could do automatic parking, automatic reverse parallel parking. When we tried it out, I was just on tenterhooks the entire time thinking, what is going on here? And I can only imagine that's what it's like for someone with long-standing diabetes starting on one of these systems and wondering, is this working? Is this doing what it should? And that can, in some cases, lead to discontinuation. So I think it's important to set expectations up front. These systems are great, but they're not a cure. They're not true, and they're not a true artificial pancreas. They are a powerful tool in the right person with the right education for improving glycemia. Just one final slide, because I think this is a final topic that covers a few points, and that's travel with AID. So this is something that someone might present to primary care about. We see it a lot. Someone's on a closed loop system and they're planning to travel. So they need a few things. Firstly, they need to make sure they've got a plan for pump failure, which should have been provided by secondary care. Secondly, they need a lot of supplies listed here. Note that this includes short-acting and long-acting insulin, such as Lantus, just so if the pump completely fails while they're overseas, they can go back to injections and stay safe. It's helpful to carry a medical letter stating the diabetes diagnosis and required medications to take this through in your cabin baggage, not checked in, and that CGMs and pumps should not be exposed to X-rays. So airport security needs to know that they should not be exposed to X-rays, and thankfully aviation security is getting more aware of this. I've got a couple of useful links there. So if anyone's got a subscription to Wilderness Magazine, they had a very good article last year about tramping with diabetes, very practical advice there. And then down below, we've got a combined document from Diabetes New Zealand and Aviation Security about airport security. So those are the points I wanted to make. I'm aware that some of that could come across as a little bit potentially negative about AID. That certainly wasn't the intention. It's just more about having a realistic idea of what these things can do and being able to have realistic conversations with patients and also being able to manage failure when it does happen.
No, that's wonderful. Thank you, Tom. Sorry, we had to turn off your video just to help with the Wi-Fi.
Yeah.
But that was really good and really lots of practical things that we can take back to our patients, which is awesome. Now, Tom, just a few quick questions. Managing hypoglycemia with an AID, do we go about it counselling patients the same as if they weren't on an AID, or is it different?
Oh, that's a really important point. Thank you for bringing that up. So generally you need much less to treat hypoglycemia on an AID system than you do on injections, and this can catch people out. And that's simply because AID, you've got short-acting insulin only. That will suspend when you're low, and in fact, it will suspend happening, which means that your insulin levels are much reduced. In contrast, if you're on injections, if you had an injection which was caused a hypo, particularly if there's Lantus around, that insulin's still hanging around. So what that means is if you take the same amount of glucose you would to treat a hypo on injections as you do when you're on an AID system, you're going to overshoot. And then what can happen is you can get really bad yo-yoing, because if you overshoot too much, you get hypoglycemia and the system reacts by giving more insulin to treat the high. So we have to counsel patients to have much less to treat their hypo. And in fact, for some very mild hypos where it's only where levels remain more than 3.5 and only slowly drifting down, the best option might be to do nothing at all and just give it time and let the system correct it on its own.
And is the dose of glucagon also lower if they need that, Tom?
No, glucagon's the same. So that's glucagon's for severe hypos. So that's given out if they're essentially got impaired consciousness to the point where they can't have something orally, and it's for either themselves or a family or friend to give to them. Thankfully, severe hypos are uncommon on AID systems. They do occur normally as a result of misjudged manual meal boluses, but when that happens, the treatment is the same.
Okay, awesome. We've got a question, Tom, around any updates about kind of eligibility for age and supply, especially around immigrants to New Zealand and refugees.
If you're not eligible for funded healthcare, then you're not eligible for these funded devices. That can be a problem. We recently, where I work, had someone who was newly diagnosed with type 1 who was visiting from overseas, admitted to hospital, and we had to, what we did for that person is we managed to get them a free sample of a CGM, because there's often free samples around, and then essentially set them on a plane back to their own country to access the funded devices in their own country.
Yeah.
So that is going to be a trickier one. Yeah.
And Tom, last question, with the additional subcutaneous insulin on top of these AIDs, we're used to kind of titrating that without the AID. In primary care, how do we go about approaching titrating that with an AID?
Oh, right, yeah. So so each AID system has different inputs in terms of what will affect the automation. So, for example, CAM-AP is one of the systems. The only thing you can adjust once it gets going is the target glucose. And you can set a glucose anywhere from 4.4 up to 11, I think. But that's the only thing you can adjust. Once initiated, that's a self-learning algorithm, and it adjusts over time. What can make a difference is those manual mealtime insulin boluses. Settings can impact the insulin delivery for those. And that setting, we think of in terms of doses, but in terms of ratios. So you'll hear there's an insulin carbohydrate ratio. So that's how many grams of 10 grams of carbohydrates, you take 1 unit of insulin. And the other one's the insulin sensitivity factor. That's the correction factor. So how many millimoles glucose will drop per unit of insulin. Those are the two things that can be changed. And you know, many well-educated patients will feel comfortable changing those themselves. The only catch to be aware of is that with both those things, the smaller the number, the more insulin is delivered. So if you reduce the ISF or you reduce the carb ratio, you're going to increase insulin delivery.
Okay, awesome.
You can adjust those, and it's sort of like with anything, making 10 to 20% adjustments and seeing how it grows over the next few days is a pretty reasonable approach.
Okay, sweet as. Cool. Thank you, Tom. Thanks for coming back for round 2 with us and education in this area. And thanks again for your very practical presentation. Awesome. I will now hand over to Dr. May Soh to talk to us about thyroid disease in pregnancy.
Tēnā koutou katoa. Thank you for having me back after I missed the initial presentation due to illness. I'm delighted to be here to share with you what we understand about thyroid disease in pregnancy. As a caveat, I am an obstetric physician and a rheumatologist, so I feel really ill-equipped to be talking about thyroid diseases in pregnancy, but needs must, and we do care for these women, so please pardon my transgressions. These are my disclosures. And just to let you know, about 60% of our referrals relate to thyroid function tests in pregnancy. And there have been a lot of misconceptions about TFTs being part of a screening test for bloods. And this has resulted in quite a lot of referrals, largely because there used to be a banner attached to every pregnant person's lab test, stating that thyroid function tests in pregnancy, the TSH should be less than 2.5. Now, this statement is outdated, and I will share with you why. So universal screening is not indicated in all pregnant persons. Test the TSH and free T4 if the woman has symptoms or has the following risk factors. The RANSCOG guidelines are actually more restrictive than what we have. For those with hypothyroidism, if they're planning pregnancy, then we should aim for a TSH within the normal range. And in early pregnancy, with the booking bloods, please include a TSH and a free T4. And while you're testing the patient, empirically increase the thyroxine dose by about 25 to 33%, even if previously euthyroid. And this is to cope with the increased fetal demand. Now, these values have been validated against the Auckland cohort by Cam Kyle of Awanui Labs. And these ranges are utilizing the Roche Cobas platform, which is used in Middlemore, Auckland Hospital, and Awanui Labs. As you can see from the third trimester, values of actually under 10 for free T4 are acceptable. Now, in pregnancy, for the initial 20 weeks of its life, the fetus is fully dependent on maternal free T4 crossing into the circulation to aid early neurodevelopment. And TSH, of course, is merely a surrogate marker, and they can be raised for a variety of reasons. So therefore, checking maternal free T4 is very useful to guide therapy. So why is this important? Well, fetal neurodevelopment starts as early as 5 weeks, way before its own thyroid kicks in at 18 to 20 weeks. So keeping the maternal free T4 at the upper limit of normal is crucial for fetal brain development for the first 20 weeks. Now, I know that studies linking maternal free T4 for neurodevelopment have been fraught, as it will be for any study that comes with many confounders, including ex utero environmental factors that support intellectual development. But this really shouldn't preclude us from doing the best possible for the next generation based on our understanding of basic embryology and physiology. So this is quite a common referral question that I get. So the woman has had her thyroxine increased empirically from 150 to 200 micrograms in very early pregnancy. But at 16 weeks, when her TSH and free T4 are repeated, her TSH remains high and free T4 is at the lower end of normal. So there are several reasons for this. Firstly, she could have insufficient thyroxine supplementation. And given that she is under 20 weeks, we would really like to aim for free T4 in the high teens. But more commonly, the reasons are malabsorption and missed doses. Now, remember, there are a whole host of drugs and supplements that can interact with the absorption of thyroxine, and quite a few of them are an elevate. So if the woman is popping her thyroxine the same time as her elevate, then the calcium and iron, which is also an elevate, will affect the absorption of thyroxine. So our usual advice applies in pregnancy when taking thyroxine, but of course in pregnancy one's expected to take a whole host of other things like elevate, calcium and iron. And for this reason, we often suggest taking thyroxine at bedtime. You can safely combine thyroxine with aspirin if the woman is using it. So due to maternal physiology, the starting doses are often much higher when hypothyroidism is newly diagnosed in pregnancy. And of course, there is some urgency to get it right, particularly if under 20 weeks gestation. The only study done in pregnancy suggests a starting dose of about 2.33 milligrams per kilogram per day to be started. So in the typical Middlemore 86 kilogram pregnant female, this would equate to about 200 micrograms per day. So starting off with 50 is probably not going to be sufficient. However, for those with subclinical hypothyroidism, so they have a normal free T4 but a high TSH, the threshold to treat is only when TPO antibodies are present. And the doses that we need are, of course, much lower, at less than 1.5 mg per kg per day. So most ex-thyroid cancer patients will have a letter from the endocrinologist stating the histology, the monitoring necessary, and it's usually ultrasound annually for 5 years, and thyroglobulin and antithyroglobulin antibodies to be quantified with set thresholds when to re-refer and also TSH targets to achieve. Now, sadly, TSH targets are seldom achieved in pregnancy. In one sad case that I will share with you, I'll let you know what happened. So in pregnancy, monitoring should remain on schedule and the targets for TSH are unchanged. They should be managed in exactly the same way as a non-pregnant person. These are the patients that we would really like to be referred on to the obstetric medicine service so that we can assist in maintaining the TSH targets. If they present with a neck mass or a suggestion that there is a cancer, then please initiate the investigations and do refer to us urgently so that we can follow this up and ensure that the woman gets her necessary surgery. So this is a case vignette that I'd like to share with you. It's based on a real patient who had thyroid cancer and a bilateral hemithyroidectomy back prior to 2018. She was given a plan to follow up and a target TSH of 0.1 to 0.5 with regular thyroglobulin monitoring and annual ultrasound scans. Unfortunately, she immediately embarked on pregnancy post-surgery, and the first pregnancy ended in a miscarriage of around 12 weeks, but not before significant hyperemesis. In her second pregnancy, I only met her at 28 weeks, shortly after I joined Middlemore in 2020. And I noted that during that time interval from her thyroidectomy to 2020, she had only one thyroglobulin level done, which was immediately post-op instead of a serial 6-monthly one. She had missed most of her annual ultrasound scans of her neck, and of course, the good old obstetric holy grail of TSH of less than 2.5 was adhered to instead of the stricter targets to suppress the recurrence of cancer. So unsurprisingly, when I repeated her thyroglobulin levels, it was sky high. And an urgent endoclinic review and ultrasound scan of her neck and FNA revealed that she had metastatic thyroid cancer. She required an expedited delivery and neck dissection within weeks of her birth, and sadly, there were nodes affected. And this is not an isolated case. So ongoing screening and follow-up of thyroid cancers remains woefully inadequate, with lots of patients being lost to follow-up as they lurch from one pregnancy to another. And most LMCs may not be aware, as the woman often feels that her cancer has been fixed. And the assumption from the LMC is that she's taking thyroxine for hypothyroidism. And this case was only referred to us in obstetric medicine clinic because of her hyperemesis, not actually because of a past thyroid cancer. So if there are learning points to be had, firstly, it's the monitoring of thyroid cancers remains exactly the same as the non-pregnant. Please ignore the gestation-specific TSH and free T4 ranges that I showed you earlier. Stick to the prescribed TSH range that the endocrinologist provides. Large increases of thyroxine are very often required, and if the woman has hyperemesis, then an inpatient stint may be needed to ensure that she continues her thyroxine. So this is a case of terrible Graves' disease, and this was a student who had a history of very poorly controlled Graves' disease and was chased down by her long-suffering endocrinologist who elicited a history of a new partner and unprotected sexual intercourse, but of course without plans for pregnancy. So the endocrinologist empirically swapped her from carbimazole to PTU. Within weeks, this patient was in the ED with fast atrial fibrillation. We saw her in the obstetric medicine clinic just a few weeks later with all the stigmata of hyperthyroidism, and we swapped her back to carbimazole at a generous dose of 20 milligrams twice per day. She was offered therapeutic clexane for a paroxysmal atrial fibrillation, but declined it. And her free T4 was impressively high at, I think, above 85. And this worrying trend continued. So we had a roundtable discussion with the endocrinologist, who assured me that carbimazole 30 milligrams BD should not leave her with any functioning thyroid tissue, and it was more likely that she was not taking her antithyroid medications. We requested an echocardiogram to look for either rate-related or thyrotoxic cardiomyopathy, and unsurprisingly, she had pulmonary hypertension. So the last straw came around 30 weeks when she was admitted with a second bout of fast AF, and fetal tachycardia was also noted. The fetal growth was tailing off, so a period of inpatient admission was proposed for some observed therapy on the maternity ward and daily fetal monitoring. This didn't quite turn out to be a huge success due to the various reasons that we found under her bed. And as she continued to have uncontrolled thyrotoxicosis, another MDT was had, and this time with the thyroid surgeons, who were persuaded to attend, as she would need a postpartum thyroidectomy. Now, she's our first patient with severe thyrotoxicosis that we actually needed to utilize Lugol's iodine on. So what is with the TSH receptor antibodies? Now, they're detected in about over 97% of non-pregnant patients with Graves, and this can persist long after a thyroidectomy or radioiodine. So it should always be tested each pregnancy in those with past Graves. Because it is an IgG molecule, transplacental transfer starts around 20 to 21 weeks, and in late pregnancy, the values do not necessarily reflect the absence of these antibodies that may already have been transferred across to the fetus. So the fetal and neonatal screening that is needed when the TSH receptor antibodies are above 2.5 times the upper limit of normal, and in Middlemore, that limit is about 3.5, and we tend to use values done prior to 20 weeks. Monitoring is also required for the mothers who are on more than 5 milligrams twice per day of carbimazole. We tend to look for fetal growth, signs of fetal thyrotoxicosis, and a fetal goiter. Postpartum day 7 thyroid function tests in the neonate are also needed, and typically the LMC is met to get them done. Now, in most non-pregnant patients with hyperthyroidism, they will be treated with carbimazole. PTU carries a very small but real risk of idiopathic liver failure in 1 in 10,000, which is why there's a recommendation to swap from carbimazole back to carbimazole after 12 weeks when organogenesis is complete. It is quite difficult to compare the risk of birth defects between these two antithyroid medications. The risk is pretty low, as you can see from the very wide confidence intervals. But in the carbimazole group, these genetic defects are quite severe. And beta blockers are often used as an adjunct to block the peripheral conversion of free T4 to free T3. So the older fashioned non-cardioselective beta blockers such as propranolol are probably preferred. So for large goiters, common sense and clinical skills will prevail and let you know when to refer more urgently and when there's a worrying neck mass. Now, each hospital will have its own referral criteria, but in Middlemore, where we have just over 8,000 births and less than one obstetric physician, we have a slightly more select review criteria, and we're of course very heavily dependent on our GP colleagues and to help with this. Now, I think I've summarized my entire talk into this one slide. So for hypothyroidism, increase the thyroxine early to ensure the fetus gets adequate thyroxine. In hyperthyroidism or Graves, past or present, TSH receptor antibody is key. And at past organogenesis, then no need to swap to PTU. For subclinical hypothyroidism, really nothing needs to be done unless they're in thyroxine or have TPO antibodies. Thyroid cancer, give lots and lots of thyroxine, keep the TSH suppressed, and monitor as per non-pregnant. Neck masses are scary, especially if there's airway compromise. Thank you.
Thank you, May. That was very efficient. And that summary slide was awesome. I just took a photo of it when you had it up. May, the empiric increase of levothyroxine. So I'm taking from that, even if we do their TSH and T4 and that's normal, we should still increase it.
Yes, please.
Cool.
Because ultimately the free T4 levels will drop, and they drop quite quickly. And by the time we see them in the obstetric medicine clinic, given how stretched our services are, it's often a little late, and sometimes it's a frantic phone call to the woman saying, "Can you please take more thyroxine right now?" Yeah.
And how long after that increase should we repeat testing? Usually we do kind of 6 to 8 weeks in the community. Is that the same in pregnancy?
We often say 4 to 6 weeks as the minimum interval. Yeah.
Okay, cool. Now, a lot of the really good info you had there, May, do you know if that is also available on health pathways for the different regions around New Zealand?
For the Auckland one, Danielle Gerard has recently updated it, and it's pretty much exactly the same stuff there. It should be pretty much the same. Yeah. Cool,
good. So we can go back to that for reference as well.
No problem.
Cool.
Thank you very much for the advice.
Thank you, May. And now we will have our last talk by Dr Sue Tutty with our timely clinical updates. Thank you, Sue.
I will start with talking about refugee health. So there's a whole new series of pathways that are available nationally. So these are right across our pathway system on refugee health, and I would just encourage everybody to have a look at them. One of the big take-home messages is use an interpreter, if at all possible. Now, we know that this is sometimes really difficult in primary care, and there is a pathway to talk about using an interpreter. And also, if you need some extra help with that, there's a called module on working with an interpreter as well. The community refugee health team have put their email in this talk and have said that if you get really stuck with a particular patient, they're happy to take inquiries from anywhere across the country. Karen Chung, who wrote the Health Pathways and also works at the Refugee Centre, did a presentation for us on the College Auckland Faculty Medicine Day recently in September, and that's on the Goodfellow site so that you can go and have a look at that as well. So you might say, well, I don't need to worry too much about refugees. They're all seen in the refugee program, and so they've all been sorted before they come to us, but that's not entirely true. Certainly we have about 1,500 refugees coming through that program, and they are mostly given good medical care before they come out to the different communities around New Zealand, and you will get a good handover with help on what still needs to be done. Sometimes all their medical problems haven't been sorted before they come to you. There's also the Refugee Family Support Program that brings in about 600 refugees a year, and they will have had no screening. And community organisations can also sponsor refugees into the country, and that's about 50 per year, and these people will have had limited screening. There's asylum seekers who have obviously had no screening. And then there's two groups that have come into the country in recent years. So that's the Afghan evacuees, that came in 2021. And they're starting to look at residency in New Zealand, so you may be involved in some of that work. They had TB screening, but very little else. And then there in 2022, there were the Ukraine refugees that came in, quite a few of those, over 2,000, and they had no screening, and particularly they had no TB screening, which is quite an issue in the Ukraine. There's all sorts of interesting information that's available on the health pathways. And just to give you some examples of some of the features that there might be, there is a syndrome-based approach, which if you scroll down into the pathway, you can find that, so that if you have someone coming to you with, say, a fever, it will give you the suggestions of things that you should perhaps consider that are a bit wider than what you might be seeing in a New Zealand-born patient. Not all refugees have literacy and numeracy skills, and there's Easy Dose, which is a pictorial representation of a medication chart, which I thought was really interesting. It shows it by sun and moon, day and night, and gives pictures of the medications to give people some idea of when to take them. Other considerations that are discussed on the pathways is something like pregnancy, where you need to think about thiamine deficiencies in people coming from rice-based diets. PTSD, which is a major problem with people who lived in a refugee situation, somatizing presentations, and lots of resources. And since we were talking about TB, just a reminder about BCG vaccinations. This pathway has also been recently updated, and a reminder that it's recommended for children younger than 5. The pathway has a really good list of who are the ones at increased risk that we should be offering the TB vaccinations to. And this is recommended particularly prior to age 6 months, because it's those young children that are most at risk of the serious complications from a tuberculosis infection and get the extrapulmonary spread causing miliary TB or TB meningitis. On a different tack, talking about e-referrals, just a note of caution that there have been some privacy concerns coming up over what's included in an e-referral, and just be careful about what health information that you put into the referral. Use your clinical judgment about what's included in terms of classification lists and medications, because they may well be relevant. I wanted to talk just a little bit about EAR, the Aotearoa Immunisation Register. So you will all know that immunisations is a key focus of this government. It's one of the 5 targets that they have set us, and that's especially the 24-month fully immunised target. So EAR was necessary because the National Immunisation Register that we had before was ageing, and it was necessary to come up with something to replace that. We had hoped that EAR would provide an answer to all our problems, but in fact it has picked up the pre-existing problems that were around with the former register. But now we have some data. The data quality issues have become visible, and we know what the problems are and why they are occurring. And this will lead to improvements in our systems and processes over the next few months. So our PMS systems are partly the problem, and we know that they're configured in so many different ways that it's very easy for these systems not to talk to each other, despite the testing that we'd done before EAR came live. There has proven to be some problems with the way these systems talk to each other. So PHOs are working on this, and working with the EAR team and working with the PMS vendors. So if you're struggling in your practice, suggest that you go to your PHO. They're probably well aware of the data issues that are there and the practices that are having problems. So they're the ones that should be able to help with this. So this slide, I think, is an excellent summary of what I've just been talking about. And you can see that there is a gap, a 17% gap of events that are recorded in our PMSs and not made it into EAR. And then there's a 19% gap of events that are in EAR and not made it into our PMS system. So these are the data issues that we're talking about and that we are working with to correct. I just want to get you to note that underneath those circles, there is a message saying 80% of childhood immunisations are messaged to EAR from the PMS system. So this means that from your practice management systems, they go to EAR. So it means that they're done in our practices. So we know that general practice is doing most of our childhood immunisations. We're the ones that will have the most influence on that target. And I just encourage you to keep immunising. You're doing great work, and we need to just keep it up. I think that most people will be aware that we're having an increase in pertussis infections at the moment, and how important it is to make sure we get those early immunisations into our babies. So nice to see that despite all the work that's been done on immunisations, it's primary care that have the biggest influence here and the challenges to us. So keep it up. Now I'm just going to my pharmac section and talking about some of the changes in medications. Again, this is quite good news that estradiol gel will be available from 1st of November. No restrictions on prescribing, no changes to other products, but it's to help with the supply issues that we've had with the patches, and it will be fully funded. And if you're interested in this will be running a webinar on this on the 12th of November. So look out for that if this is an area of your interest. Fosfomycin is a medication that has previously been available with a whole lot of restrictions and difficulties to get hold of it, but it's an oral medication that allows us to treat in the community bacteria that have proven to be resistant to most other antibiotics, and well, to all other oral antibiotics that we've had available to us. So it will be available now that we can get it easily in primary care. It does need a special authority, and you can see what the special authorities I've listed there, so that the patient has an acute symptomatic bacteriologically proven uncomplicated urinary tract infection with E. coli, and that they're either resistant to all our usual medications, or the patient has a contraindication or intolerance to those medications. And there is Eufos as the branded medication that's available, and that will be there for 2 years. There's been some reports of difficulty accessing CGMs in the community, and again, good news, we're not short of them. There's plenty of supply. The issue was with the supply chain and getting the supply from the suppliers to the wholesalers to the pharmacies. So if you're having people reporting that they can't get hold of the CGMs, ask them to go back to their pharmacies, ask the pharmacies to talk to the wholesalers, and let's get them out to the people that need it. And my last section is on looking forward, system change thinking. And you may have heard the discussion that's been around about the proposal to increase prescribing duration from 3 months to 12 months. So there's been a discussion document out, and I would reinforce that no decision has been made at the moment. Unfortunately, the time to put submissions in has closed, but I thought it was still useful to be aware that this is being talked about. The idea is that it would be a change that would enable patients on long-term stable medication to receive longer prescriptions, so prescriptions that would last longer. And there's a website that you can go to read a bit more about this. The current dispensing limit at the moment is for how much medicine can be collected will remain at 3 months. So that's the same as it is now, that you can get 3 months at a time. So what will happen is if you get a 12-month prescription, you'll get your initial dispensing, and then you'll get 3 repeat dispensings to last for the rest of the year. And the proposal will not affect the prescribing restrictions for medicines that are controlled drugs and ones that have already been restricted. So I had a look at what was happening overseas, and this is looking at 31 other countries and what their prescription duration is and what their dispensing duration is. And you can see that New Zealand is well in the minority of only allowing prescriptions for 3 months. And the cutoff is somewhere between 6, 9, 12 months. So certainly towards higher prescription durations. So there's advantages and disadvantages with this. More convenient for the patient in many cases, because they're not having to come back to the doctor or to get more medication, or to the nurse practitioner. And improved adherence, because they're less likely to run out of their medications, and so able to keep taking them. And there will be lower costs for both the patient and for the healthcare systems. But there are also some disadvantages, and I think there's an increased clinical risk if we're not seeing patients for a year at a time. It will be important to choose the patients that get the extended prescription, and this can possibly increase inequities. Certainly, there's increased medicine wastage because patients may get a longer supply and not necessarily take it or use it. Less interactions with healthcare professionals, and some patient dissatisfaction if they're not being given the maximum length of time that they feel that they could receive. So lots of issues around this, and so it will be still a hot topic for discussion going forward. So that's the end of my presentation. Any questions?
Cool, thank you, Sue. Those are all great and relevant topics for us tonight. We do have a couple of questions coming through, Sue. One around your topic on refugee health. Are there any malaria issues that come through with the refugees and ongoing screening for this with them?
So I'm not an expert on refugee health, and I might leave that for someone else to answer. I would suggest you go to the pathway and have a look. Yeah,
I'm sure there's a good section on malaria in the pathway. Cool. Now with the AIR register, Sue, for immunisations, we've got a question here about, which again you may or may not know, about why AIR sends us information about patients that we have vaccinated, kind of clogging our system unnecessarily.
I think that if you're getting that, then it means that those vaccinations haven't been recorded on AIR if they're still sending you reminders. So I would say that that's what we're talking about, a data issue. And we know that some practices are certainly struggling with the information that we're getting to and from AIR. And this is why I wanted to just bring it to everybody's attention. We know about it, we're working on it. Contact your PHO if it's a particular problem. They're probably aware of it and working on it on your behalf. But just to be aware that, yes, there is information not getting there at this stage and information that they have that we're not getting, but hopefully we can iron out some of this. And unfortunately, we had to change our immunisation register, so we're hoping that it will, within months, a lot of these data issues will be fixed.
Cool. So that's all our questions for tonight. Thank you to our three speakers. We really appreciate your time. And we'll see you next month for the next Te Tiri Whakāro episode. Thank you, team.